On the next slide, we've got plantar flexion. So if you add plantar flexion with some of these other movements, you can isolate certain muscles. Plantar flexion with the knee straight is gastrocs. Plantar flexion with the knee bent is soleus generally. Same thing when you stretch. Okay? Plantar flexion with inversion is tibialis posterior. Plantar flexion with eversion, that's peroneus longus. Peroneus brevis is on dorsiflexion side, so you can scratch that off. And these are the same, just the opposite of the extensors. Again, general rule, whichever joint you're testing at, you can stabilize on either side of the joint. Okay. Any questions about dorsiflexion and plantar flexion, how to isolate muscles? For inversion, eversion, just realize when you have somebody invert and invert, you're testing a whole bunch of muscles. Okay? So what you would normally start off with is general resisted range of motion, plantar flexion, dorsiflexion, inversion, eversion. If they have pain with inversion, you may have to test every single one of these muscles to see which one is problematic. It'll help you be more specific with your rehab plan. This is just a table that takes a look at the toes with flexion and extension, the range of the motion, and then the end fields. And as you can see, all the end fields are tissue stretch. Okay. This is just a picture of how you would measure ranges of motion in the ankle. I think we did this. Or the ankle groups did this when we did principles of assessment. One of the ones that were mostly challenging were the inversion, eversion, and where you have to put the goniometer. So that's the back of the heel, that's the Achilles. So you're looking for which joint for inversion, eversion. Where does it happen? Subtalar. So you got to look for the subtalar joint. So malleolus, just below the tips of the malleoli, subtalar joint. So that's where the axis is. The stationary arm goes along the midline of the tibia. The movable arm is in line with the midline of the calcaneus. And what some people do is they'll just put a little dot wherever they think the middle of the heel is. And they'll align that dot with the axis, and that's where the moving arm is. And inversion, eversion is based off of that.
So sorry, where does the movable arm align to?
The calcaneus, or a midpoint on the bottom of the heel.
Oh.
Okay. Checkpoint. What ranges of motion should be painful if there's a problem with? Okay, so in your group, so 4, 3, let's have 5 and 4. If it's a lateral ankle sprain, knee down sprain, the muscles that plantar flex, what ranges of motion should be painful? So you should have a list of these active ranges of motion would be painful, these passive ones would be painful, and these resisted ones would be weak and painful. Okay? So if the lateral ankle ligaments were problematic, medial, which ones would be painful? Okay, so we'll give you 5 minutes to chat about that. If you need to get your foot up on the table and move it around, by all means. Okay. Let's go through them. You guys can talk about this after. Again, just to let you know that there's a lot of this that is not black and white in real life. Okay? We'll just try to come up with the obvious, but again, keep an open mind because you might get some stuff that's painful that you wouldn't really expect. The reason why I put this up is this is how we make scenarios for the CAT exam. Okay. If we're giving you a lateral ankle sprain, we're like, okay, well, what range of motion should hurt? And therefore, the model has to mimic that during the scenario. So you guys be asked to do that as well. So we kick somebody out, and you're the patient. We're going to say, give this person outside, and when they come in, give them a lateral ankle sprain. You have to be familiar with what range of motion you have to say out with. Okay? So let's take the first one, lateral ankle sprain. You guys, which ones would be black range of motion? You guys in the back, passive range of motion. What would be painful?
We said those two potentially, if you took all the way to the end range.
And for overpressure up there, repeat for overpressure?
Yeah.
Same?
Yeah.
Okay. Resist range of motion, you guys?
Inversion.
Sorry?
Inversion.
So resistance range of motion is at mid-range you're testing.
Oh. We didn't write down.
So what do you think? Let's say it's a mild ankle sprain. Anything resistant would be painful?
Eversion.
Eversion maybe?
Eversion and inversion I've had people complain,
Okay.
they hurt both.
Okay.
It's resistant.
Okay. From a anatomical standpoint,
It should be when you're resistant inversion.
why?
Those are the muscles, like the ligaments are torn on that side or sprained on that side.
Okay.
So those they contract. I don't know how to explain it.
Okay, so there might be some relationship between the tendons and the ligaments. There might be. So if by contracting the muscles you think you can visualize them pulling on the torn ligaments, it could potentially be painful. Okay? But generally speaking, if you're in mid-range and you're just testing isometrically, it shouldn't be. It really shouldn't, but you will have instances where it will. A lot of times it will be painful. But if you're strictly looking at it from an anatomical standpoint, you're not stressing the ligaments if it's in mid-range. Which is why isometrics in mid-range are the first exercises you do to keep up strength. Because you shouldn't be stressing the ankles because it's in mid-range. Okay? So generally speaking, let's just leave that blank for now.
So when someone does something like that, it's because of the associated muscle?
It could be the associated muscles, like it could be more severe than you think. So if you get stuff here in a real patient, it's probably more severe. I just threw out mild ankle sprain. Okay? So from an anatomical standpoint, this shouldn't really be painful. Good. Let's skip that second one and let's drop to plantar flexion. So we did ligaments. Let's do muscles now. So you guys, active range of motion. Plantar flexion should hurt. What else? Eversion.
Inversion?
Inversion.
Yeah, we had a bit of a
Why?
We didn't get to that one.
Oh, okay, okay.
Oh, we're not doing medial ankle.
No, we're skipping that. Oh, sorry. My bad. So we did ligaments, let's do muscles. We'll finish off with that.
Yes.
Plantar flexion?
Yes.
Dorsal flexion?
Yes.
Yes.
Why?
Then a stretch.
Hey! Inversion, eversion?
Yeah.
Yes.
Maybe it's
They help a
useful.
little bit, but.
Yeah, probably not as much. These are the main ones. Overpressures. Passive range of motion. Plantar flexion? Passive.
Potentially.
No.
No, you're still stretching though.
Yes.
Inversion, eversion, we're still in trouble. Good. Resisted.
Plantar flexion.
Plantar flexion for sure. Dorsiflexion? If not, if you're testing in neutral. Right? Like your plantar flexors aren't working at all. If you're testing dorsiflexion, resist it. Okay? And then the rest of it, same idea. Okay? So I hope you guys start doing that with when someone presents with something, that goes through there. And then test it to see if it is actually true. Let's leave it at that for today. On Tuesday, we'll do pathology. And then next week, Friday, we'll continue with the hands-on stuff with special tests. Nice. If you have any questions, let me know, okay? Okay, have a good one.